Okay. Thank you. So, good afternoon, all. A hearty welcome for our ninth episode of Academics with Institution program. So, we are back with yet another prestigious institute from Central Zone. That's SN Medical College, Sarojini Naidu Medical College from Agra. So, hearty welcome to our Honorable President, Dr. Vasant Kalatkar, sir. Thank you for constant support. And hearty welcome to our President-elect, Dr. Neelam Mohan ma'am. Our immediate past president, Dr. Basaraj sir, hearty welcome to you. And Dr. Yogesh Parikh sir, our honorary secretary sir, is traveling, so he might join once flight lands. And Dr. Atanu sir, hearty welcome in absentia. So, hearty welcome to our respected chief guest sir, Dr. N.C. Prajapati sir. Thank you so much for accepting to be our chief guest for this episode. And our whole department of SN Medical College, headed by Dr. Pramod Kumar sir, who is also the chairperson, hearty welcome. Professor Neeraj Kumar, Dr. Anamika Goyal, Dr. Megha Agarwal, and the postgraduates, Dr. Gargi Sharma and Dr. Sunil Gupta. So we are able to have SN Medical College mainly because of the efforts of Vice President of Central Zone, Dr. Guru Prasad sir. Hearty welcome to you and thank you so much. And the coordinator, Dr. Ghanshyam Chaudhary sir, thank you so much. And I welcome our past president, Dr. Pramod Jog sir, and our president-elect 2026, Dr. Singaruvelu sir, and VP 2026, Dr. Devendra Sarin, and all those who have joined in today. At the outset, I would request our Honorable President, Dr. Vasant Kalatkar sir, to give his opening remarks.
Yeah, I'm audible?
Yes,
Audible?
sir. Yes.
Yeah. Good afternoon, all. Respected President-elect Dr. Neelam Mohan, or past President, that's 2024, Dr. G.V. Basavaraja, our Secretary General, Dr. Yogesh Parikh in absentia, Dr. Atanu Bhadra, our Treasurer. Then Dr. Guru Prasad has joined, our Vice President Guru Prasad. Then our past President Dr. Pramod Jog and President-elect 2026 Dr. Singaruvelu. Congratulations, Dr. Singaruvelu. Then our key persons in this, Dr. Priya. Thakti nahi kabhi. That is the great thing about Priya. Who is whose brain, and along with Dr. Jagdish Chinappa, our coordinator, Dr. G.S. Kancham Chaudhary, Dr. Ruchira Gupta, Secretary 2026-27 of IIP. Prajapati sir, namaste. Then our today's heroes mainly. So Dr. Pankaj Kumar, who is leading the institute SN Medical College, Dr. Neeraj Kumar, Dr. Anamika Goyal, Dr. Megha Agarwal, who had taken a lot of effort for this, and our presenter today, Dr. Sharma and Dr. Gupta. So it's a really proud moment for me that we are having a ninth episode. And unfortunately, due to election, as there was no activity in October month, we missed once. Otherwise, it could be a 10th episode. But really, I'm proud of this team led by Dr. Priya and Chinappa, conveyed by Dr. Ghanshyam Chaudhary, that they are in continuous touch with this. And definitely our Dr. Guru Prasad, today's convener and everything, who could connect all these with SN Medical College, Agra and Medi. Dr. Guru Prasad, your specialty that once you decided, अगर नहीं decide किया तो नहीं करोगे, but once you decided, you always do it, and that's your last word. So really, thank you for this team. Definitely, Agra team, and I hope next year, next month episode, Priya is going to tell along with Vice President. Definitely, there is a very good backing of my team, my all executive board member and office bearer, along with Dr. Neelam, Dr. Basavaraja, Dr. Yogesh, Dr. Atanu, Dr. Ruchira, Dr. Parmanand. They all are OB, and all 5 vice president. They are always encouraging me to go for any activity, whether it's academic or social. And today, that's why we are still looking after this ninth episode. And I think let's hope that two more episodes should be there, at least two more episodes should be there. So this is not a effort of a single, let's say IIP or me or our office bearer, but it's definitely effort by all our coordinator along with the college. And this new idea started last year. It's making wonder that give recognition to one good institute, and not only institute but those who are doing the job greatly, like Dr. Pankaj Kumar and Dr. Agarwal and all team. That we wanted. Basically, it's a really sharing of knowledge, but it's a sharing of the organization who is the presenting, sharing of the college and staff, what it was and how they are working, and they're going to show their everything. That was the basic aim. So I wish that this episode should be continued for next year also. Then only we can highlight more and more institute. Because of this, our all 59,000 members will come to know what are the institutes in India. They are working nicely. Once again, I welcome you all and wish you all the best for the thing. Thank you.
Thank you. Thank you so much, sir, for your constant support and encouragement. I now request our respected President-elect, Dr. Neela Mohan ma'am, for your address.
Thank you, Priya. Respected Vasanji, Basav, and all the VPs who are available here, not only of the previous year, I can see a lot of faces of the new year too, right from the Devinder Sareen and Dr. Ruchira, as well as Athano, Arun Sharma. So we have a lot of people today, though I can't see Singravelu, my apologies, maybe I'm not able to see him. And Guru, seeing you after a long time digitally, it's nice.
Yeah, ma'am. Thank you. Thank you, ma'am.
So today's Dr. Vasant has already beautifully highlighted how indebted we are to Dr. Basav, who started this legacy about talking of the institutes. And as more and more institutes are being explored from his time and followed by Dr. Vasant, I'm sure there is a lot more to explore in the coming year too. So that we understand. But I think today's topic is extremely essential because we realize that Agra is a state where we are talking, especially when we talk about this institute. One of the first things that strike the mind is the specialized newborn center which they have created, and it's very important and nice because though it has more than, I mean, close to 75 PHCs and community health centers and 2 district hospitals. But this hospital has got really popular for its specialized newborn care unit and the facilities with which it is equipped with, right from the ventilators and CPAPs, especially for newborn. So that is commendable that they are able to do it, and it is a need of the day in that place because UP is still struggling when it comes to the NMR of 28, the last statistics show, as compared to the rest of the country. So hats off to all the people who are beautifully posed and poising in. I can see them. Is that you, Pankaj, thinking about it? I can see a group standing there which says Pediatric SNMC Agra. So I wanted to congratulate you. We are all ears to listen to you. But it is also very good when we talk about the institutes to talk not only on the strengths, but also on what the weaknesses we have so that we are able to see what best we can do. But yes, I know that you all are famous not only for your specialized newborn unit, but also for your care in the children. And I'm also aware about the endoscopy unit, etc., that you people are geared up with. Heartiest congratulations. We are all here to listen to what you have to share with us. Wish you all the best. Thank you so much for this opportunity.
Thank you. Thank you so much, ma'am. I now request our immediate past president, Dr. Basavaraj sir, who laid the foundation for this program, request to address, sir.
Yeah, thank you so much, Dr. Priya, respected our National President of Indian Academy of Pediatrics, Dr. Vasant Kalatkarji, President-elect, waiting for a few days to take over, Dr. Neelam Mohanji, and of course, Dynamic Secretary General, Dr. Professor Yogesh Parikji, and Dr. Atanuji, Ruchira Madam, Guru Prasad, our Central Zone Vice President. This is a flagship program of Indian Academy of Pediatrics, which is basically looking into what the teachers require, what the postgraduates requires, what the practitioner requires, all the things which is going to be there. Very happy. Today's chief guest, Dr. N.C. Prajapati sir, who is a well-known medical teacher and also the Dan in the field of pediatrics, who has been here invited as a chief guest when the SN Medical College is going to share their experience with the Dr. Pankaj Ji, Neeraj, Dr. Anamika and team, who are going to share the whatever the research which has been there. So this is a program which is going to give something to all the postgraduates as well as teachers and practicing pediatrician. Best wishes to the things. I'm sure the incoming team led by Dr. Neelam Mohanji, Dr. Ruchira Madam, Dr. Singaru Velu, our President-elect of 2026, I will take the program with another innovative way to the newer heights. Best wishes for the today's program. Thank you very much.
Thank you. Thank you so much, sir. Hearty welcome, Atanu sir. Thank you for joining. Dr. Ruchira Gupta ma'am, thanks for joining. And we are missing Dr. Jagdish Chinappa sir, our advisor, as he is traveling. So moving on, I would now request our Central Zone Vice President, Dr. Guru Prasad sir, for your address and to introduce our respected chief guest, sir. Over to you, sir.
Yeah, thank you, ma'am. Thank you for giving this opportunity to address this August gathering. Thank you, Dr. President, sir. And my respects to all seniors and elders over there. Congratulations to the entire new team who are eagerly waiting. I could see our Singarvelu sir, our Devendra sir, and our Ruchira ma'am, who is going to take over as HSG. They want to rock next year. All the best. And I wish all the best to the SN Medical College team to do well. And Priya ma'am, please finish your introduction. Na? You do finish
Yes,
off
sir.
your introduction. Yeah.
Please introduce chief guest, sir.
No, ma'am, you can do it. Right. Thank you.
Okay.
Okay, ma'am. Right.
Yeah, it's my honor and privilege to introduce our respected chief guest, Dr. N.C. Prajapati sir, who is the Vice Chancellor of KM University, Mathura. He has done his MD Pediatrics and MLBMC from Jhansi. He was formerly Principal and Dean of GMC Agra, Jalgaon and Badau, Director General Medical Education, Government of UP, and he has been associated with many research projects of ICMR, WHO, UNICEF, and he is an expert in public service commissions. Sir has more than 50 publications in national and international journals, and he has written chapters in books also. And sir's area of interest are adolescent and community pediatrics. Thank you so much, sir, for accepting to be our chief guest. Request for your address.
Thank you, Dr. Priya, and Dr. Vasant, our president. He is a very old friend of mine. Dr. Neelam Mohan, president-elect, Dr. Basavaraj, Dr. Atanu, Dr. Guru Prasad, Dr. Ruchira, Dr. Pankaj and his whole team at SN Medical College, Agra, Dr. Pramod Jog, and all the dignitaries present here. Sorry, I will not be able to name everybody. It's really a privilege that a very good program has been started, and this is a way that all the medical institutes which are promoting academics, actually they are lacking as far as academics is concerned, because the academics is more outside the academic institute, and it's a good initiative that now the academic institutes are being pipelined in such a way and taking the old institutes. As far as SN Medical College is concerned, I was a faculty there. I was the principal and dean there. And then I was also the Director General of Medical Education. So I always wanted that the SN Medical College should come up because it's one of the second oldest college. Some call it the third oldest college in the country. And I have been visiting this when I was at Sevagram as examiner to medical college. That time it was not very good. This I'm talking of 1995. But now a very good neonatal unit and every other things, many other things they have developed here. So the research, the number of postgraduates that we have over there, a lot of work is being done, and they are taking the projects of the Indian Academy of Pediatrics to the public. We have seen the number of awards that IAP Agra is bagging at the national level and at the state level. It speaks of the commitment of the pediatricians of Agra and the faculty of the SN Medical College Agra in the efforts they are putting to the public for the improvement of the child health. Dr. Pankaj, who is presently the HOD of the department, Dr. Neeraj, because we have got headship by rotation, and Dr. Neeraj, who is the former HOD of the medical college, they are really doing a lot of the community work and the academic work. So all the very best to the presentation that we see over here, and thank you all very much for giving me this opportunity to be a part as chief guest in the institute of my choice. Thank you very much and all the best.
Thank you. Thank you so much for your inspirational words, sir. Yes, Vasant, sir.
Yeah, thank you, Prajapati sir, for joining this and accepting as a chief guest. Really, it's a proud that you're my friend. Thank you.
Thank you. Thank you, sir. I would now request our EB member from Jhansi, Dr. Ghanshyam Chaudhary, sir, to introduce our chairperson, Dr. Pankaj Kumar, who is also the professor and HOD of SNMC.
Thank you very much, Priya ma'am. Respected President Sir, Vasant Kalatkar sir, President-elect Neelam madam, and President 2024, Basar Raja sir, BP Guru Prasad sir, and all dignitaries on the desk and off the desk also. Dr. Pankaj Kumar, he is MD, PDCC, MAMS. He is graduated from KGMU Lucknow, one of the oldest college, and post-graduated from MLN Medical College, Allahabad. And he did PDCC from ILBS, Delhi. At present, he is professor and head of department, SN Medical College, Agra. He is having more than 18 publications in various national and international journals, multiple presentations in various conferences. So welcome you, Dr. Pankaj.
Thank you, sir, for your kind introduction. At the outset, I will like to thank IAP for giving us this opportunity. Thank you, President, sir, President-elect Dr. Neelam Mohan ma'am, Secretary HSC Dr. Yogesh Parikh, who is presently in the travel. Thank you all for giving us the opportunity. So without any further delay, I will like to give the presentation of the institute. So SN Medical College Agra is one of the 3 oldest medical colleges, as sir has said earlier. Initially, it was established in 1854, and at that time it was known as Thompson Hospital. And primary aim of this hospital was to train doctors for the Indian Army. But later on in 1872, it was opened for the general public also, and at that time LMP course was being done, which was later named as LMSF, by the UP State Medical Institute. In 1939, it was upgraded as medical school, and then MBBS degree was started in 1942. My slides are visible or not?
Yes, yes, visible, sir. Please continue.
Okay. So, in 1949, it was named as Sarojini Naidu Medical College after the first female governor of the UP, Srimati Sarojini Naidu. And presently it is affiliated to the Atal Bihari Vajpayee University. So, as you know that Agra is the city of the Taj, and because of the Taj Mahal, we are blessed with this, and we have to look after for the highly distinguished individuals who used to come here. Because of that, various international, dignitaries, they used to come in the Agra. Our medical college is not only giving education for the MBBS and MD students or MS students. We are also training paramedicals in various streams. And last year, DM and MCH courses in the urology and neurosurgery has been started in our medical college. So this is our central library, which is now a heritage building, and it is more than 100 years old now. As far as Department of the Pediatrics is concerned, it was the first department established in the UP in 1962, and Professor R.S. Dayal was the founder of this institute. Professor Ramesh Prasad and Dr. Rajeshwar Dayal, they are the two stalwarts who have received VC Rai Award respectively in 1992 and 2016. So this is the list of our faculty members. We have very, very good faculty here. 11 faculty members are there. We are getting the services of our Professor Dayal also, and he is still giving us his full support to the medical college. So we are regularly doing all the academic activities assigned by the central IAP, like Autism Awareness Week, Breastfeeding Week, Thalassemia Day, Down Syndrome, and SARS Week, etc. And we are conducting divisional round of the prestigious IAP quiz for MBBS students. So as far as other clinical facilities are concerned, we are equipped with the 27-bedded emergency, and we are providing ventilation facility in the emergency itself. So it's not available at most of the other centers in the UP that ventilators equipped in the emergency department. In the emergency department itself, we are providing services for the hemophilia and thalassemia patient. We are giving factor 7, factor 8, and factor 9 for the hemophilia patient free of cost. And blood transfusion is being done for thalassemia patient. And we are also providing chelation therapy, and it's also being done free of cost. So this is one of the picture. We are having 24-bedded NICU and equipped with ventilators, double bubble CPAP and phototherapy, and bedside echo machine, where we can, which is very helpful in catching early heart disease. We are planning to upgrade this SNCU further with the high frequency ventilators and hypothermia machine. So this is a breastfeeding area, separate breastfeeding area, TMC area. We are also having endoscopy lab, which we have developed this year only, and we are first in the state. I am very proud to say that we are having separate GI unit, pediatric GI unit in our department. Another services we have started is communication directly to all the peripheries. So basically, this was a project which was named Center of Excellence, in which we are connecting with the peripheries, and we are providing support to the CSC and PSCs for newborn and intensive care patient. We are also having we are providing support to the new medical colleges like ETA and Firozabad, which are in the developmental stage. So these are the future plans. We are planning to have high frequency ventilators with inhaled NO and therapeutic hypothermia facility in the NICU soon. And we want to start bronchoscopy and bedside disease in EEG in the future. Thank you. Now I will request Professor Neeraj Kumar, who will be presenting keynote address on a neurodegenerative disorder. I request Neeraj sir to please present. Sure. Stop sharing. Can you see the slides?
Yes, sir. Yes.
Right. So Dr. Neeraj, he's professor in the Department of the Pediatrics, and he's having very keen interest in the area of the neurology. And I will request Dr. Neeraj to present, please.
Thank you very much, Dr. Pankaj, and IAP dignitaries present on online. Thank you very much. Now I present overview on neurodegenerative disorder. The hallmark of neurodegenerative disease is regression and progressive deterioration of neurological function with loss of speech, vision, hearing, locomotion associated with seizure, feeding difficulty, impairment, and impairment of intellect. Neuroregressive disorder are group of heterogeneous disease which result from the specific genetic biochemical defect, chronic viral infection, and toxic substances. Involve both white and gray matter. White matter diseases appear in the later stage and gray matter diseases in early infancy. White matter contain a mostly myelinated axon, appear pinkish, and connect various matter areas of gray matter areas of the brain and carry impulse. Gray matter, gray-brown in color and neuronal cell body and dendrites. It controls muscle, sensory, perception, vision, hearing, memory, and emotion and speech. Causes of the neurodegenerative disorder like SSP, chronic rubella, chronic HIV, metabolic disorder like chronic lead poisoning, hypothyroidism, vitamin B12 deficiency, vitamin E deficiency, and anticonvulsant drugs like phenobarbital and phenytoin and valproic acid. Leukodystrophy like metachromatic leukodystrophy, Graves' disease and adrenoleukodystrophy, Alexander disease and Cameron disease. Acquired or demyelinating disease like multiple sclerosis, Schindler's disease, Davick disease, Smith-Lemel-Office syndrome. Now I describe Smith-Lemel-Office syndrome. Smith-Lemel-Office syndrome is a rare autosomal recessive genetic disorder caused by mutation in VHCR7 gene, which lead to low cholesterol level and accumulation of abnormal cholesterol precursor in the body. Cholesterol is essential for the brain development, growth hormone production, and cell membrane structure maintenance. When cholesterol is low, many organ systems are affected. Key feature of this syndrome are microcephaly, ptosis, broad nasal bridge, small chin, low satia, syndactyly, cleft palate. Development and neurological disorder like global developmental, intellectual disability, hypotonia in infancy, later on hypertonia, behavioral difficulty, autism, feature like aggressive irritability and do not communicate and interacted. Seizures. Also have a growth and feeding difficulty and some congenital abnormality like gastrointestinal, generative urinary and organ malformation like congenital heart disease, lung abnormality, GI abnormality, structure, brain malformation is there. Behavior and psychiatric feature like sensory process problem, self-injurious behavior, autistic trait, anxiety, sleep problem, severe irritability during metabolic instability. Silos occur when the enzyme 7-dehydrocholesterol reductase does not work properly. This results in low cholesterol and high 7-dehydrocholesterol. Diagnosis confirmed by the metabolic blood test and genetic testing. Diagnosis made by elevated 7-DSC dihydrocholesterol and low total serum cholesterol and genetic confirmation by DSCR7 gene mutation. Management, there is no cure, but treatment aimed to supportive and development, reduce the metabolic and increase life expectancy. Cholesterol supplement, dietary and medical emulsion, high caloric feeding in infant, management of reflux and feeding issue, seizure management, physiotherapy, occupational therapy, and speech therapy. Surgical correction like for the cardiac and genetic anomalies if required. Behavioral support and autistic support enrolled in support program. Prognosis highly variable, mild cases survive adulthood and few difficulties in survive in life and learning difficulty. Severe form can have a life-limiting complication in infancy due to the organ malformation. Thank you very much. This is now hand over to the Dr. Pankaj.
Thank you, sir, for giving us a view of neurodegenerative disorder with this specific emphasis on SLOS. So, I can, house is open for the questions if anybody want to, or should I go for further presentation?
If
Dr.
any questions we can take, sir, we are having time.
Yeah. So if anybody has any questions regarding the SLOS or neurodegenerative disorders, then all right. I think we should move for the next presentation. Dr. Priya?
Yes, sir. Please come.
Okay. So next, I will request Dr. Megha to present about the research project and which has been published, or few research projects which are presently in the department. Dr. Megha, please.
Thank you so much, sir.
Yes, sir.
Share with you, sir. Is the slide is visible?
No, your slides are not visible. Stop sharing, open that particular PPT and then share, Dr. Megha.
It is not visible.
No, it was in a small this thing, not full screen.
Now it is
Yeah.
visible.
Yes, make it full screen.
Now it's okay.
Thank you so much, sir, for this opportunity. I will tell you in brief about research activities in Department of Pediatrics. Our department is doing various research on the neonatal sepsis, tuberculosis, leprosy, and various ICMR projects, WHO projects, and various vaccine trial is going on in our department. These two papers are recently published in the Lancet Global in 2024. This is the multicentric randomized control trial, and it is done by the WHO. And in this first paper, we taken the young infant with the single low mortality risk sign for the possible serious bacterial infection, and we found that the sorry. In this first paper, we taken the infant with the single low mortality risk sign of the possible serious bacterial infection, and we found that the oral antibiotic treatment such as the IV gentamicin plus ampicillin is as effective as the inpatient treatment, and we also found that the mortality is less in the outpatient treatment. And in second paper, we taken the young infant presented with the moderate mortality risk sign of the possible serious bacterial infection and early discharge in this patient with the oral antibiotic is as effective as the conventional intravenous inpatient treatment. And we also found that the hospitalized infection is less in this patient. This paper on the cardiac troponin I as the earliest diagnostic indicator in asphyxiated neonate was published in 2024 in Journal of Neonatology. This paper on the antioxidant status in the neonatal sepsis, a case control trial, was published in 2022. This paper on kangaroo mother care, a low-cost intervention for improving cerebral hemodynamics in the preterm babies, was published in 2024. This paper on presepsin and interleukin-6 as a potential marker for neonatal sepsis was published in Journal of Neonatology. This meta-analysis was published in European Respiratory Journal in 2023, and it stated that the global estimate and determinants of the tuberculosis drug pharmacokinetics in children and adults. The study on diagnostic accuracy of the CPNAT in stool sample in pediatric tuberculosis was published in IGP Journal in 2024. This case control study of comparative evaluation of the multiplex PCR, RLP PCR, and LAMP PCR in urine, stool, and blood sample for diagnosis of the pediatric leprosy was published in Indian Pediatrics in 2024. This scientific letter is recently published in 2025 in Indian Journal of Pediatrics on diagnostic role of LAMP in nasal swab and slit skin smear specimen in pediatric leprosy. This study was published in Nepal Pediatric Society on vitamin D level in pediatric asthma at tertiary care center. This study was published in Indian Journal Gastroenterology in 2023 on the role of the cholangitis in the children with the biliary atresia. This study was published in Indian Pediatrics on the epidemiological profile of acute viral encephalitis. Our Professor Dr. Neeraj sir is the co-author of chapter in Textbook of Pediatric Intensive Care based on the Clinical Practice First Edition 2024, and he also co-author of chapter in Textbook of Common Medical Disorder in Pregnancy. Our Professor Dr. Dayal sir has an implication on the new WHO guidelines for tuberculosis in the Asia Pacific region, Asia PAC Pediatric Child Health Volume 6, July-September 2023. Various phase 4 drug trials are completed in our department, such as the safety and efficacy of the amoxicillin and potassium clavulanate oral suspension in the children with the URTI or LRTI infection. A fixed dose combination of paracetamol 250 phenylephrine hydrochloride 5 mg and CPM 2 mg per 5 ml syrup in symptomatic treatment of the common cold in children. And also the same with the other fixed dose combination of the paracetamol 125, phenylephrine 5 mg, CPM 1 mg per 5 ml syrup in symptomatic treatment of the common cold in children. Various studies is ongoing in our department, such as the impact of emollient therapy for hospitalized very low birth weight newborn on their survival and healthy outcome, a randomized control. This is the ICMR project. Second is implementation research to develop and evaluate a health system model to integrate the immediate KMC into the routine care of the preterm and low birth weight infant in Uttar Pradesh. This is the WHO project. And various phase 3 vaccine trial is going on the hexavalent vaccine, IPV vaccine, and MR vaccine. Thank you, sir. Over to Pankaj, sir.
Thank you, Dr. Megha, for giving a brief overview of the research projects which are under going and for presenting the various publication which was from our department.
Sir, if you can brief on the safety and efficacy of the paracetamol, CPM, phenylephrine in children, because it's the hot topic now, it
Right,
would be helpful.
Right. So it was found to be safe in the patient in the patients who are more than 2 years of the age. Dr. Neeraj was the PI in this project, so I will get the comments from him also.
Actually, these combination drugs are available in so many drugs combination, so many drugs available in combination in the market. But जो few combination are those are not जो normal इनमें content present है वो उतना है या नहीं है. दूसरा ये इसमें जो है जो इसमें लोकल मेडिसिन काफ़ी ज़्यादा अवेलेबल हैं, काफ़ी ज़्यादा मार्केट में अवेलेबल हैं. उसमें से बेसिकली दिक्कत वही कर रहे हैं जो है केवल फॉर्मूला अपना उस पर टैग लगाकर सोल्ड करते हैं जो नॉर्म्स और जो टैग लगा के अपना फॉर्मूला बना के सेल करते हैं और उनका जो है लोकल मार्केट में बनवाते हैं, लोकल फैक्ट्री से बनवाते हैं, जिसके कारण ये दिक्कत हो रही है. लेकिन जो हम लोगों ने ट्रायल किया उसमें ऐसा कोई कॉम्प्लिकेशन नहीं आया. जो बच्चों में जो इन्फेंट इवन ड्रॉप का भी हमने ट्रायल किया था 1 साल के कम के बच्चों में, उसमें भी ऐसा कोई कॉम्प्लिकेशन नहीं था कि जो है इसमें कोई दिक्कत जैसे ये ओवर सेडेशन और ओवर लॉस ऑफ लाइफ डेथ हो जाए या फिर जो है रेस्पिरेटरी डिप्रेशन हो. लेकिन इसमें ये दिक्कत है कि कभी कभी क्या होता है फीवर, बच्चे फेब्राइल होते हैं तो ओवरडोज कुछ लोग दे देते हैं, उसमें थोड़ा सा ध्यान रखना चाहिए. और जो प्रेस्क्राइब डोज है डॉक्टर के द्वारा वही डोज दी.
Thank you, sir. So, sir is telling it was safe to be used even in less than 2 years with the drops you used, no, sir?
Yes.
Okay. Thank you, sir. Please continue.
All right. So next in the line are 2 case presentation, and Dr. Anamika will be. Dr. Anamika, are you there? Dr. Anamika?
Yes, sir.
Okay. So she will be coordinating the 2 cases. The first case will be presented by Dr. Sunil. Dr. Sunil, please come. And he will be presenting case on abnormal body movement. अच्छा So he'll be presenting a case of abnormal body movement with regression of the milestone. Can you see the screen now?
No, sir. Please stop sharing, open that PPT and then share, sir.
Stop sharing करो पहले. हाँ. अब start. Right. Is
Yes,
it
yes,
visible
yes,
now?
yes. Yeah.
Okay. So he'll be presenting a case on abnormal body movement along with regression of the milestones.
A very good afternoon to all the respected faculties. Myself, Dr. Sunil Gupta, Junior Resident in Department of Pediatrics, SNMC Agra, and I am presenting a case history of a 13-year-old male child, resident of Manburi, born of non-consanguineous marriage, second by birth order, informant being mother, and presented the chief complaint of recurrent episode of abnormal body movement for 5 years, abnormal behavior for 5 years. A sequence of events during episode of abnormal body movement was or at onset characterized by behavior changes like feeling scared, running around the south and shouting, deviation and angle of mouth to right side, deviation of eye to right side, tonic-clonic movement of right side of the body, followed by dystonic posture of the lower limb and upper limb of the left side of the body. Seizure lasting for 4 to 5 hours and post-ictal phase lasting for 2 to 3 hours. One episode in 1 to 2 months associated with vomiting and bladder incontinence. Abnormal behavior included self-harming behavior like biting, suffocating himself by putting pressure on the neck with his own hand, lack of interest in surrounding, decreased scholastic performance, inattention in class, inability to read and write, sleep problems, irritable and aggressive behavior, tendency to run out of house if left unattended. Second. Negative history, no history of alloy discoloration of eyes and urine, no exaggerated shuttle reflex, abnormal urine or sweat odor, skin or hair changes, hearing and visual impairment, or no history of pox, no history of single complaint family and siblings. Past history, at the age of 5 years, there was a history of hospitalization due to complaint of fever with unconsciousness or present details are not available. There is also history of recurrent hospitalization due to abnormal body movement. Immunization, antenatal, natal, and postnatal period are uneventful. Immunization history, complete immunization as per NIS schedule. Family history, no history of similar complaining family or sibling. Dietary history, during course of illness, there is 70% calorie deficit and 52% protein deficit. Developmental history. Child attained all the milestones appropriate for age till 8 years of age. After 8 years of age, there was gradual progressive regression of acquired milestone and currently child is able to do following activities. In gross motor, child is able to do hops on 1 foot, skip on 1 foot, goes down stair with alternate feet, not able to skip rope using both the feet. Developmental age is 4 years. Fine motor, able to make tower of 3 block, able to scribble spontaneously, not able to copy horizontal and vertical line. Developmental age is 18 months. Key social, able to tell name, gender, not able to decide right and left side, not able to play in group. Developmental age is 3 years. Language used like I, me and you, not able to tell story or poem. Examination, on examination, vital of the patient was stable, and in general examination, pyelonephritis, sinuses, clubbing, edema, or lymphadenopathy were not present. Head to toe examination in head, occipitofrontal circumference was 52 centimeter, which is less than -3 standard deviation, and suggestive of microcephaly, and hairs normal in color. Facial dysmorphism present like broad nasal bridge, small chin, and low set ear present. Eyes in eye examination, ptosis, bilateral ptosis was present. No obesity, no sign of vitamin A deficiency, no cherry red spot, no obesity, optic atrophy, or no retinitis pigmentation seen. Ear normal shape and size, oral cavity, oral hygiene was poor. Chest and abdomen normal, symmetrical in shape and size. Limbs, all the four limbs are extended position. Back normal. No neurocutaneous marker present. No hyperpigmentation seen. CNS examination, higher mental function of the patient was conscious, recognizes mother and stranger, and speech examination, scanning speech present, is arthria present. Memory, able to recall name of school and teacher. Cranial nerve examination, all the cranial nerve are intact, no meninges are present. Motor system examination, bulk of bilateral symmetrically reduce all the four limbs, and tone of all the four limbs increase. Upper limb tone is more than lower limb tone. Spasticity present all the four limbs. Power is 4/5 in all the four limbs. Deep tender reflexes are not elicitable. Superficial reflection, plantar was extensor, rest are intact. Sensory system normal on examination. Cerebellar scientist diadochokinesia and get present. Other systemic examination are within normal limit. So on the basis of clinical feature and examination, I would like to keep my differential. First, neurodegenerative disease, in which Smith-Lemli Opera syndrome, mitochondrial disorder, lysosomal storage disorder, and peroxisomal disorder. Second differential is chronic demyelinating disorder, in which CIDP and SSP included. On MRI scanning, deep white matter changes has been seen in the frontoparietal temporal or bilateral internal capsule. EEG findings, there is a variable pattern of slowing of the waves followed by increase in frequency seen. Investigation, routine investigation was within normal limit. In specific investigation done in view of the my differential, in which lipid profile, serum cholesterol was low and HDL was also low, 39.8.4 milligram per deciliter, and serum cholesterol was 104 milligram per deciliter. ACTH was normal, USG whole abdomen was normal, and 2D was normal. ABG, in ABG finding, there was no lactate level increase, was normal. Findings suggestive of Smith-Lemli Opera syndrome. In history, abnormal body movement was present, which is GTCS type. Abnormal behavioral as well, like self-harming, decreased scholastic performance, aggressiveness, sleep problem, and regression of milestone. Examination, microcephaly present, facial dysmorphism like broad nasal bridge, low CTA, small chin present, ptosis present, increased tone in all the four limbs present. Not elicitable deep tender reflexes, and plantar was expansion. At aggregate, reddish diadochokinesia present. In investigation, MRI showing changes in deep white matter, and EEG variable pattern of slowing of the waves followed by increase in frequency seen. Lipid profile, serum cholesterol level was low and HDL was low. To confirm the diagnosis, genetic workup has been sent and report was awaited. Treatment, patient was already on anti-epileptic medication on valproate. We switched the patient to tablet valproate and tablet carbamazepine, and seizure are under control. Patient has also been started on oral risperidone and syrup melatonin for controlling behavior abnormalities and better sleep pattern. Plan to work up for intellectual disability and autism. Thank you. Thank you.
Thank you, Dr. Sunil. Now I will request Dr. Dinesh for his comments about this case.
This case, a 13-year-old male presented with a complaint of the neuroregression with seizure. This pattern usually seen in neuroregression disorder. This pattern seen after 3 years of age. After 3 years of age, so usually this happen in mitochondrial disease and lysosomal disorder diseases, and some few demyelinating syndrome and SSP, like SSP and chronic rubella syndrome and chronic HIV, some toxic use of toxic substances like lead poisoning and vitamin E and vitamin B12 deficiency, and some demyelinating disorder also. So most probable this not fully work up done, but this is investigated for the MRI shows white matter diseases and EEG variable pattern and blood investigation shows ABG is normal, serum lactate is normal, and no hepatosplenomegaly. So this initially kept as a mitochondrial disorder, but ABG is normal or lactate level is normal, and ptosis is there, and serum cholesterol level is low. So kept other differential diagnosis in mind. So the most probable this case kept as a Smith-Lemley office syndrome. Thank you.
Thank you, Neeraj sir. The house is now open for the questions.
Yeah. Hello.
Yes.
Yeah. Good afternoon, Dr. Neeraj and Dr. Pankaj. I'm Dr. D.K. Singh from Noida.
Ji sir.
So first of all, congratulations for presenting this your journey of the department in this esteemed forum. Actually, I could join late, so I have missed some part of this case in the beginning. I just wanted to know, could it be Wilson's disease possibility? Did you exclude the
Yes.
possibility of Wilson's disease in this child?
Maybe chronic, but there is no sensory involvement is there, and no LFT is also normal.
Normal.
It was a very close possibility in presentation. If we just see then abnormal behavior, and then these were very close possibility of the Wilson disease was there. But
yeah, because it's a treatable disease.
Right, sir, right. And we should always consider a treatable cause. We should always look for a treatable cause in such type of the disorder, so that at least we can have something for the patient. Good news for the patient. Unfortunately, the workup was, was not suggestive of the Wilson.
Okay. Because the name of the syndrome is tongue twister, I am still not able to take the name. Okay, thank you.
Thank you, Dr. D.K. Singh, sir, for joining. We had your institute last year. I was remembering you were the chairperson.
Yeah. Yes,
Thanks for joining, sir.
Thank you.
Yeah, please continue, sir.
Any other question from the
It's
house?
a relation with the autism, if you can brief little bit.
Actually, autism, this is neurodiversity. So this is not treated by a medicine, or there is no medicine effective in treatment of the autism. So many programs available in the centers. So it change the behavior and change the improve the interaction and attention span of the baby. If we increase the attention span and interaction and social communication improve, then all of these conditions like aggressiveness, irritability, self-defense, and exaggeration, all are decreases, and anxiety are decreases, and obsessed and compulsive disorder also decrease if baby attached to environment and family member, or able to connect to environment and local things.
Thank you.
So I think I should move to the next. Yes. All right. So next case will be presented by Dr. Gargi, and Dr. Anamika will be moderating this case.
Okay,
Dr.
sir.
Okay. इसको स्टॉप शेयरिंग कर स्टॉप शेयर कर शेयर कर क्लिक करो इसको बनाने का कोड मेरा देखिए Are slide visible now?
Yes, sir. Continue.
Okay, Dr. Gargi, now please.
Make it full screen.
So what are we actually in this? ये जो ये है ना इसको ऐसे मूव कर दो Slides are visible or not?
Slides are visible, not in full screen.
Now it's okay?
Yeah, now it's fine. Please continue.
Please. आराम से ज़्यादा केस नहीं
Good afternoon, respected faculty member. Myself, Dr. Gargi Sharma, Junior Resident, Department of Pediatrics, SNMC Agra. I am presenting a case of 1.5-year-old male child resident of Ajnera, born out of third degree non-consanguineous marriage, second by birth order, informant being mother, presented with chief complaint of fever for 1.5 months, abdominal distension for 1.5 months, difficulty in breathing for 3 days. Fever was high-grade, intermittent in nature, associated with rigor, needed down medication. Abdominal distension was insidious in onset, gradually progressive, more in upper than lower abdomen, not associated with pain in abdomen, constipation, vomiting, and loose stool, not associated with swelling of any other part of the body. Difficulty in breathing, increased on lying down position, relieved on sitting position, associated with cough. No history of weight loss and loss of appetite, no history of bleeding manifestation, no history of yellowish discoloration of body and high-colored urine, no history of joint pain and transient rashes. Antenatal, natal, and postnatal history are not significant. There is a history of previous blood transfusion, first at 5th month of age and second at 17th month of age. Immunization history was incomplete, last immunization at 9 months of age. All developmental milestones are achieved, appropriate for age. There is no history of a similar complaint in any family member, no history of blood transfusion in any sibling, and no history of TB contact. Patient has a calorie deficit of 80%, protein deficit of 20%. Vitals. At the time of admission, patient is tachypneic with sign of respiratory distress. Respiration was abdominothoracic type. Patient was also febrile. Temperature was taken in left axilla, which is documented as 101 degree Fahrenheit. On examination, general examination, pallor present, severe grade. Head to toe examination, skull and head normal in shape and size, frontal bossing present, hair were sparse, hyperpigmented, and easily pluckable. Eyes are normal, ear normal, chest apparent flattening of right side of chest with ICD in situ and dressing present. Anthro was done in which weight for height is less than -3 standard deviation. MUSC is 12 centimeter, which is under moderate acute malnutrition, and length for age is between -2 to -3 standard deviation. Weight for height is less than -3 standard deviation. So patient is under severe acute malnutrition. On systemic examination, abdominal examination was done. Shape of abdomen fullness present more in upper than lower quadrant. Umbilicus is normal in shape. Liver 6 centimeter. Liver is palpated 6 centimeter below the right costal margin in right midclavicular line. Firm in consistency, smooth sun with sharp margin and non-tender. Spleen size 10 centimeter. Splenic notch felt on anterior border. Smooth surface, firm in consistency, crosses the umbilicus. No free fluid in abdomen. On respiratory examination, type of respiration is abdominothoracic. Movement decreased in right side. ICD was placed with dressing present over the right infraaxillary and inframammary area. Symmetry, asymmetrical movement decreased on right side. On percussion, dull note present in the right inframammary, infraaxillary, infrascapular, and interscapular area. On auscultation, air entry decreased in right inframammary, intraaxillary, interscapular, infrascapular area. Liver was 6 centimeter and spleen was 10 centimeter. Basic routine investigation was done, in which basic CBC was done, in which hemoglobin was 6 gram per deciliter. Total leukocyte count are 3,820 cells per millimeter of cube. Platelet are 80,000 cells per millimeter of cube. MCV was 96 femtoliter. ALT and AST are slightly raised. CRP is positive 68.3 milligram per deciliter. Blood culture is sterile. Viral marker are negative. Chest X-ray was done at the time of admission, which shows the gross pleural effusion in the right side. So ICD was placed. Other investigations are done to rule out differentials. For disseminated Cox, pleural fluid was sent for investigation, which shows no FV and gram stain was negative. GSCB net was done, in which MTB not detected. Pleural fluid is exudative type. Pleural fluid AD is negative. USG whole abdomen was done, which showed no necrotic lymph node and no enlarged mesenteric lymph node. For chronic malaria, MP antigen is negative and IgM antibodies are negative. For storage disease, no refractory hypoglycemia. Glucose was measured. Fasting glucose is also measured, which is also normal. ABG is normal. Plasma ammonia normal. Urine for reducing substance absent. Urine ketone absent. Urine for glycosaminoglycans absent. GVP was done for Gaucher cells, which doesn't show any Gaucher cells. Bone marrow biopsy was done for further investigation. For hemolytic anemia, HPLC was done, which is normal. It is done prior to first transfusion. Retic count is 1.5%. LDH is 257, which is normal. Indirect hyperbilirubinemia not present. Serum iron and ferritin are normal. GBP shows normocytic normochromic with few macrovalocytes, moderate thrombocyte and no hemoparacyte. For malignancy, CBC with RC done, bone marrow aspiration and bone marrow biopsy was done. For histiocyte, lymphocytic, hemophagocytic, lymphocytic histiocytosis, serum ferritin was normal, triglyceride normal, fibrinogen normal, and solvent CD25 was done, which is also normal. Bone marrow aspiration was done, which shows histoplasmosis marrow. Descriptive morphology was, which is seen in the aspiration, is the smear show reached the form of histoplasma capsulatum in many histiocytes. For the confirmation, we have done the bone marrow biopsy. There is a presence of the increased number of histiocytes. These histiocytes and giant cells show yeast form of histoplasma intracellularly as well as extracellularly. For the another investigation was done, which is urinary galactomannan antigen test for histoplasmosis, which is positive, which shows 26.64 enzyme immunoassay unit. After that, whole exome sequencing was done, which shows RPL15 gene positive and FOXN1 positive, which shows the diamond blackfan 12 and T cell immune deficiency, which are of uncertain significance. Certain studies are published which shows the diamond blackfan syndrome association with the immunodeficiency. And histiocytosis, so treatment done for the disseminated histoplasmosis was intercostal drainage tube was placed in the right 50 intercostal space for the gross pleural effusion. IV fluid and oxygen are given at 5 liters per minute for the respiratory distress and tachypnea. Amphotericin B lipid complex was started and supportive treatment was given in the form of antipyretics. Histoplasmosis is caused by Histoplasma capsulatum, a dimorphic fungi. Histoplasma capsulatum thrives in our soil, rich in nitrates, such as areas that are heavily contaminated with mud, and bed droppings or decayed wood. Inhalation of microconidia, fungal spores is the initial stage of human infection. Most of the infection are asymptomatic or self-limited. Children with immunodeficiency are at increased risk for disseminated histoplasmosis. Clinical manifestation of histoplasmosis can be acute pulmonary histoplasmosis, which will manifest like a flu-like symptom like headache, fever, chest pain, cough, and myalgia. Progressive histoplasmosis occur in which fever is the most important, which persists for the weeks and months before the diagnosis is done. Other findings are hepatosplenomegaly, pancytopenia, and the interstitial pulmonary disease. Next is chronic pulmonary disease. Chronic pulmonary histoplasmosis. Thank you.
Thank you, Dr. Gargi, for your presentation. Dr. Ramka, are you there? Your comments on the presentation?
Yes, sir. So it was an uncommon diagnosis, but it made us think that why histoplasmosis first of all occurred in this patient. Then when we asked from the patient retrospectively, then we got the history from the patient that he used to live near a canal and he had a kacha veranda in front of his house. Where the child used to play for hours, and the peacocks and birds and they all used to frequent that veranda. Then we thought of it that why disseminated histoplasmosis. Then genome sequencing gave us the answer. Though genome sequencing reveals mutation of uncertain significance, but maybe in future, this is still an open field. Maybe in future we will come to know about the significance of this mutation, because disseminated histoplasmosis usually does not occur in immunocompetent individuals. So I would like anyone to ask any questions.
Yeah, Dr. D.K. Singh from Noida, very well presented and very well investigated case. Just a query what was the finding after treatment? Did this liver, spleen and all regressed and counts improved after treatment? How many months of follow-up do you have in this patient?
No, sir, we could not follow up. So this was the problem. Actually, hearing of the immunodeficiency, the father of the child, he wanted to take the child to some higher center. So we referred the child. We talked to the father a few days back only. He told us that the child is fine. But he did not provide us with any papers or something like that, what was exactly treatment was given to him, because he was not at his home.
So he was not treated at your place?
No, so we started on amphotericin B, but then after that, the patient was referred. Yes, sir. Yes, sir.
Because this treatment will not be done in any smaller center. He must have gone to some higher center, bigger place, and spent a lot of money on that.
No, so he wanted, actually hearing of, when he heard of this immunodeficiency and all that, so he thought of consulting a higher center.
Okay, because I have not seen any case of histoplasmosis in any child till now. In spite of managing a lot of HIV children, in HIV it's no, but even those children do not have this infection as a common infection.
Yes, sir.
Okay, thank you.
Okay, thank you.
Actually, sir, this patient, initially we were, we should say, roaming around the bushes. So we were trying to find out the cause, and we are doing all the investigation. And in the bone marrow, suddenly we found that this thing. So we were also surprised after seeing this patient that histoplasmosis there.
But Dr. Pankaj, what I would suggest, you can just call the patient and have the feedback what happened to this hepatomegaly, massive splenomegaly, and all, and what treatment, because amphotericin B will not be given in any small hospital. So where he went and how he completed treatment, whether he completed treatment or not. So these are the questions. But usually parents.
So as discussed by my teams, the patient is doing well, but we wish to see him again, and we want to examine and work up, follow the patient.
Yes, sir. We have talked to him, and he said that whenever he returns home, he actually works outside. So whenever he returns home, he would try to come for the follow-up.
Yeah, you can give some incentive for such cases that he will be paid transport charges. So that way he will be having some incentive. He doesn't have to spend money while coming to you.
जी
So
sir,
that is
जी
an
sir,
incentive for such patients. A good
definitely sir.
case, very well managed, very well investigated. Thank you.
Thank you sir.
Any other question from the house?
So you can stop sharing. We
Stop
can
sharing.
see.
Okay. So, right.
Yes,
No other,
Pankaj sir.
no other comments, any
No,
comments?
we have comments, but any questions we can take now, sir, if anybody has any questions or suggestions.
So over to you, Dr. Priya, now.
Yeah, thank you. Thank you so much, Dr. Pankaj sir,
I
and the
think
whole
we
team.
have not delayed the things.
You were on dot on time well before the time finish. So very glad that presented well presentations from all the postgraduate, especially very well extensively worked up cases, and you had the diagnosis. So very happy to listen to the cases, sir. We have our past president, Dr. Pramod Jog, sir. We are really privileged today to have, sir. We missed him for the last two sessions. Over to you, Pramod Jog, sir, for your comments and jokisms.
Thank you. I hope I am audible. Yeah, that's
Yes.
fine.
Yes, yes, sir.
Oh,
Yes.
thank you. Thank you. So it was a great pleasure listening to all our friends, colleagues, juniors from this Sarojini Naidu Medical College in Agra. And I remember that one of my colleagues had told me that it's a great government medical college and named after the first lady governess of UP, a poetess and a freedom fighter, and known as Bharata Kokila, okay, Nightingale, Srimati Sarojini Naidu. Yeah, and it's one of the oldest medical schools of India. And I, know that in addition to Lahore and Kolkata, Agra was one of the oldest medical schools, founded in 1854. And we had Dr. N.C. Prajapati as the chief guest and Dr. Pankaj Kumar, professor and head, as the chairpersons. And I was so proud to know that Professor Ramesh Prasad and Professor Rajeshwar Dayal are the BSERA awardees from this institute. And Dr. Pankaj told us about some important aspects of this institute. And I remember he told us that it's having a comprehensive management center for hemophilia and thalassemia, which is a great boon from people from that part of UP. And also, apart from institutes like SGPGI in Lucknow, there is a pediatric GI unit also. That's what I remember what he told. And also, it's serving as a center of excellence for the colleges in the periphery. And I think Megha told us about the research in neonatology. What I could remember is the recent publication by the department related to this possible serious bacterial infection. And if I get it right, then the outpatient management of the young patients with low mortality risk, of course, those who have risk of mortality on the lower side, and thought of having possible SBI. In the resource limited settings, you could probably treat them on the OPD basis so that the risk of infant deaths and the healthcare costs could be reduced. I am so proud of this department for this study because it's very important for our country, and I feel this particular study can continue so that with changing times we can have further evidence to support what we are saying. And of course, we had a nice presentation related to that Smith-Lemli-Opitz syndrome. They had short formed it as SLOS. And actually, there are various important points related to the neurodegenerative disorders. And when I was in my final MD, neurodegenerative disorders in children was a full question. And that's why I remember that, of course, in the medical colleges these days we always ask our students. So what our colleagues must remember is that there are some important points about these neurodegenerative disorders. So these are often present in infancy or early childhood, and symptoms that may be initially very subtle. And these conditions typically cause gradual loss of the previously acquired skills. Okay, so the skills are acquired, the milestones are acquired, but then these motor and cognitive and language and social abilities slowly they decline. And many of these neurological disorders are inherited, and they're commonly autosomal recessive or autosomal dominant, or some of them are X-linked related. And then important examples, as our colleague said, they are like leukodystrophies and Tay-Sachs disease, spinal muscular atrophy, ataxia, telangiectasia. They are common disorders. And basically, the symptoms overlap with other developmental disorders. And that's why the diagnosis is very, very difficult. Okay. And genetic testing and MRI and the metabolic tests, and sometimes the enzyme assays are also crucial. And for most of the conditions, currently, we don't have any definite cure, and the treatment is supportive or disease modifying at the best. And many pediatric neurodegenerative diseases, they commonly involve the abnormal metabolism of the lipids or the carbohydrates or the amino acids. And developmental regression is a red flag. So loss of the milestones, for example, losing the ability to walk or talk, that's often a key indicator. It prompts the neurologic evaluation. And beyond the brain, these disorders can affect basically vision, hearing, and the muscles and the autonomic functions, and sometimes other organs. So it was great that they presented this case also, and Professor Neeraj Kumar and then his one of these postgraduates, they mentioned about this this Smith-Lemli Opitz syndrome. So what one should remember about this syndrome is basically if you get a child with developmental delay with dysmorphism. Okay, so we learned that it's basically a problem with the cholesterol biosynthesis defect. So a child will come with microcephaly and global development delay and dysmorphism. So a practicing pediatrician could remember a child coming with global development delay, microcephaly, and dysmorphism, at least suspect this condition. You can have low set ears and some other dysmorphic features. And of course, those who are interested can go and further refer, to find out as to what is the type. Of course, there is no specific treatment, as I said. So sometimes, people give cholesterol supplements, or if there is some problem related to the, like biliary stasis and all, I know that people give bile acid supplements or statins. And as Professor Neeraj Kumar said, the main thing is to support the development and reduce the metabolic complications. And of course, the case presented by Dr. Gargi, and which was guided by Dr. Anamika, was of histoplasmosis. And basically, this is a fungus, and we all know that fungal infections are common in the immunocompromised, children, and that's why in these children these cases become progressive. And the resident told us that either it can take an acute form or become progressive. Particularly what happens is many of these patients, they mimic tuberculosis, and when they don't respond to the routine therapy, one should always suspect fungal infections. It could be candida, it could be aspergillus, it could be histoplasma, and then tissue biopsy, of course, many times is the diagnostic one. Why I remember this histoplasmosis is because we had, during our MD exams, one examiner was very khadus type, like thode say some examiners, they have their own questions, So he would ask us, a question, Pramod, tell me what is the, cause of stone spitting? I never heard, he was asking me, what is a condition where a child can spit stones? So actually, I was thorough with my Nielsen at that time. So I had read at that time that histoplasmosis is one condition where, you get fibroma-like lesions, and they are, like in following tuberculosis, we get calcific lesions. So in histoplasmosis, you get those fibroma-like lesions, which are concentrically calcified. And, these are called as, like stone spitting. So child spits it out. So there is wheezing and hemoptysis, and that had fetched me the gold medal at the exam. So I have a special connection with histoplasmosis. And of course, this child was put on this amphotericin B. That was a great thing. But I agree with one of our seniors who said that, these children need to be followed up. And I'm glad that the resident has really taken all out efforts to rule out disseminated COX and storage disorders and hemolytic anemia and chronic malaria, malignancy, and HLH. So that was quite impressive. And the bone marrow biopsy, which showed these, histiocytes and giant cells with the yeast forms of this fungus, they were, along with that urinary galactomannan, finally clinched the diagnosis. So I'm glad that our students have presented these cases very well, and I wish them all the best. And particularly in this city of Taj Mahal, which is the epitome of love, I wish all the best, and I wish the love towards children by all the faculty members continues forever. And I'm sure when I come to Agra and visit the medical college, I get the Panchi Petha and the Dalmot, so very famous of Agra. Thank you.
Sure, sir. Welcome, sir.
You are most welcome. It's always a pleasure to hear you.
Thank you. Thank you so much, sir. Indeed, it's an honor to have you in our program. You lighten up and awaken everybody, whoever is sleeping at the end. Thank you. Thank you so much, sir. Before going to the vote of thanks, I would request our chief guest, Dr. Prajapati, sir. Thank you so much for staying till the end, listening to all the presentations, for your opinions or the closing remarks from you, sir.
Definitely, I think after Dr. Pramod Jog has summarized everything and in such a way that, and the word khadus, that stands true for all, all
अब
our.
सबको सोचना पड़ेगा सर कौन किस कैटेगरी में आ रहा है
स्टूडेंट पीरियड याद करा दिया सर ने
I remember that in NRP,
सोचना पड़ेगा
when we did that and I was sent for training. सर आपको इसलिए भेजा जा रहा है कि आप एक खड़ूस इंस्ट्रक्टर हो. So very good word used, and after a long time, and Dr. Pramod Jog, you always really hit the point. So once again, a big thanks to all. Dr. D.K. Singh late joined here, but he was very interactive, and the others who were there all around. Dr. Rakesh Bhatia has joined. Dr. Sareen was there since the beginning. So thanks to all of you, and it's a very good activity because I belong to, as a faculty, to SN Medical College. I had been principal dean. So really, thank you for being a chief guest of this, and all the best to all of you.
Thank you. Thank you so
Thank
much,
you,
sir.
sir. Thank you, sir. Thank you, sir.
Yeah, just a reminder, we are having the next and the last episode on 19th December. We are having Nalanda Medical College from Patna. Request all of you to join. And thank Dr. D.K. Singh, sir, Dr. Rakesh Bhatia, sir, Dr. Arvind Sharma, sir.
Just
Yeah,
one second.
all of... Yes, sir.
Dr. Pankaj is somehow is tied with Sarojini Naidu. He did his MD from Sarojini Naidu Children Hospital, Allahabad. And now he's working in Sarojini Naidu Medical College. It's just coincidence.
Sir is following Sarojini Naidu name.
So I think next stop is again the Sarojini Naidu only. I have to search for any third institution which is named after Sarojini Naidu in India.
क्या बात है सर क्या बात है
And we need to have a survey from the postgraduates who will fit into Kadus examiners. So on the lighter note, I would now request our coordinator, Dr. Ghanshyam Chaudhary, sir, to deliver the vote of thanks. Over to you, sir.
Thank you, Priya ma'am. So thank you very much, our ever smiling President, Vasant Kalatkar, sir, for joining us. Lady with charisma, our President-elect, Dr. Neelam Mohan, madam. Mitochondria of our IAP, Mr. Raja, sir. Teacher of teacher, President-elect, Dr. Singara Velu, sir. And special gratitude to Pramod Jog, sir. It is always pleasure to listen to you whenever you talk. And a great teacher, educator, administrator, Professor N.C. Prajapati, sir, who joined us as a chief guest. And always ready to help our Vice President, Dr. Guru Prasad, sir, our HSG, Yogesh Parikh, sir, our Treasurer, Dr. Atanu Vadra, our HSG-elect, Dr. Ruchira, Dr. Deven Sarin, sir, Vice President-elect, and our co-EBs, Dr. R.N. Sharma, sir, Sanjeev Kumar, our past EB, Dr. D.K. Singh, and many other seniors like Rakesh Bhatia, sir, Dr. D.K. Singh sir, who joined us to grace this occasion, and all the team of Medical College Agra, Dr. Pankaj Kumar, Dr. Neeraj, Dr. Megha, Dr. Anamika, Dr. Gargi, Dr. Sunil Gupta, who presented very well today's sessions. And special gratitude to Chinappa sir and Dr. Priya. They are continuing these sessions from 2 years, and I hope this will continue next year too. So, last but not least, a special mention and special thanks to all participants who joined online from different places. And a special thanks to Team CIAP too. Without their support, it was not possible. Who's provided us technical support. Thank you all for joining us.
Thank you. Thank you so much, sir. Congratulations and thanks to the whole Department of Pediatrics, SNMC Agra. And thanks to Pramod Kumar, sir. I would have troubled him in coordinating. Thank you so much for all the presentations. Thank you, sir. Thank you. And thanks to Saji from the backend team. Thank you.
Thank you, Dr. Priya, for your continuous support.
Thank you, sir.
You started dot in time. You're finishing
sir.
dot in time. That's great.
Yes.
Okay, thank you.
Thank you, sir. Thank you.
Thank you, Priya madam.
Thank you, Devendra Sarin, sir.
Bye-bye.
Thank you all. Congratulations.
Thank you, sir.